You're listening to the Active Mom Podcast with host Dr. Carrie Pagliano. I'm a mom, physical therapist, and your go-to guide for staying active with pelvic health issues in pregnancy, postpartum, perimenopause, and beyond. Whether you're a fellow mom, physical therapist, or women's health professional, join me where I'll share expert insights, real-life stories, and the latest research to help you approach running, CrossFit, yoga, Pilates, HIIT, or whatever activity you love with confidence and evidence-informed guidance. Let's start the show. All right, I'm really excited to welcome our next guest, Dr. SINEAD Dufour. She is a Canadian physio who has her hands in all of the things. So we're going to have a really fun conversation today. SINEAD, welcome to the Active Mom Podcast.
Hi, Carrie. Thank you so much for having me. I'm excited to chat with you today.
I feel like this is a long time coming. I feel like we've kind of danced around each other for a long time.
Definitely.
I know who you are. Well, tell us a little bit about who you are, where you're from, and kind of what got you into pelvic health and what you're kind of focusing on right now.
Yeah, of course. So I'm SINEAD Dufour. I'm here in Canada, as Carrie said. I'm just outside of Toronto in Ontario, and I'm really what I would call an academic clinician. So I spend a lot of my time kind of in academic things. I've been a physio for over 20 years now at this point. I focus in pelvic health. I'm a pelvic health physiotherapist. I am sort of a co-founder of a company called The Womb, The World of My Baby. So this essentially is an integrated perinatal care center. We have 6 of them now in Ontario. So I run my practice through one of those centers just outside of Toronto. At the minute, actually, my practice is sort of virtual only for my care, but it's kind of through a shared care model because, of course, there's a lot of clients that either want or would benefit from in-person care, and I'm able to integrate that with my 6 different teams depending on where someone lives in the province, which has been really cool. So that's also become a bit of an interest of mine. But what I would say with pelvic health is how I became interested in this area in the first place was really through my own experience having twins. I was almost through my PhD when I got pregnant with twins. And my PhD and postdoctoral fellowship research really had nothing to do with pelvic health, but it had everything to do with how can physiotherapists with their skill set best position themselves to optimize primary health care. How can we best serve the population needs as they evolve and kind of work in teams and improve access and have really innovative care designs like group care and these types of things. So I really have carried that sort of sentiment with me as I have focused now in pelvic health, but then I myself became pregnant with twins and navigating that space after, even as a physio, I was a physio for about 7 years at that point, and just seeing the care gaps and seeing an opportunity for our profession, I kind of jumped ship. In Ontario, it wasn't till 2012 where we could kind of actually get rostered into pelvic health. And so that was about a year after I had my kids. And so it just seemed important to me at the time to kind of go ahead and do that. And so at this point, kind of everything I do is mostly in this sort of pelvic health, perinatal sort of care focus. I've had an interest in diastasis over the years and pregnancy-related pelvic girdle pain. And we'll kind of, I'm sure, get to a lot of those topics today.
Yeah. So I think our oldest, well, your twins and my oldest, probably almost the same age. I'm almost, my son's almost 14. So
yes, my kiddos turned 14 in December. So they're 2010 babies.
Okay. So how's it going? You're doing okay?
Doing okay. They both started high school this year and we are doing good. Yeah, we are doing good.
It makes 0 sense because they were babies like a hot second ago. So.
I know, right? Totally. I'm with you.
All right. I want to start actually, you had mentioned virtual care, and I know you have a little bit of pilot study history and stuff looking at virtual care, and that started back in 2019. Now, jump ahead a year to 2020 with the onset of the global pandemic. There was a big rush to everything virtual. And then I feel like some people really took to it and some people did not. They thought that physios, we were all about our hands. There's no place for it there. I personally had done some before that, and I feel like it made me a better therapist. But I'm curious kind of what was your look at virtual care prior to the pandemic? And then how do you see that evolving? Because I do think it's a tool that we really need to leverage more.
100%. So I agree with you, Carrie. I think because I was already doing it before the pandemic, that really set me up well. And that set me up well, actually, to lead my team and help empower them. But how that started for me, I would say, actually came from the work I did in primary healthcare.
Mm,
So I was already very sensitized to this notion of we need to make sure we are meeting population demands. And simply put, individualized one-to-one in-person care doesn't allow you to match service for demand. It just doesn't. So I was very quick to, when we got the womb going, to have sort of like group visits in groups and, integrating kind of service provision through a virtual means where it was appropriate.
mhm.
And where it was appropriate was where people were living sort of outside of
Right.
the area. And also where I found it quite appropriate, and I sort of switched my practice early on, was actually in peds care.
Mm,
So I found for peds pelvic health PT
mhm.
very quickly, sort of that first session was a lot of discussion with the parents, and typically it was
Right.
mom. And a lot of the time there was this very young child kind of in the visit, kind of having, a hard time trying to focus, understandably, for an hour, while a lot of sort of the conversation was with the mom. So I very quickly transferred to say, you know what, always my first initial consultation for peds out of the gate will be virtual, because it's more with mom, and hopefully have the child kind of come in and say
Yep.
hello to me. And I kind of kept that as sort of a bit of a running thing. And then I also was able to, because I do a lot with pain science and pain care, and so much of that care is very psychologically
Yep.
informed. So I found in a lot of my other kind of cases like that, I would give people the option to say, yeah, you can come in. But given that a lot of the work we're doing is more of this psychologically, behaviorally informed care,
Right.
that it is really more us kind of doing almost more like a motivational interviewing and
Mhm.
back and forth in some of these cognitive interventions. Didn't sort of need people to come in. And actually, I found like the care was better that way, because there wasn't an expectation for me to start doing tissue care when that really wasn't what we should be doing
Yep.
for the benefit of that client. So yeah, so I had a little bit of that done before, and had kind of done some pilot work and some look at that from that perspective. Pandemic hit, everything shifted. And then through the work I actually do with the Society of Obstetricians and Gynecologists of Canada, so I've sat on a number of their committees over the last over the last decade now. I've led some clinical practice guidelines. One of the guidelines that we led, that was published, I think, in 2022, was really looking at sort of like e-health and
Mm,
technologies for incontinence.
mhm.
We had updated the guideline for conservative interventions for urinary incontinence. And through that, we were seeing so many papers kind of that didn't fit what we call our PICO questions, like they didn't fit our research questions,
Mhm.
but it showed us that it was relevant for us to look at these other interventions around e-health and m-health solutions.
Mhm.
And virtual care was a piece that came up through that.
Yeah.
And actually, our findings was that there's really good evidence. So it's a strong recommendation in that clinical practice guideline for virtual care
Right.
for incontinence. And, I'm actually supervising a master's student at McMaster at the moment. And her thesis topic is looking at virtual care for physio, for pelvic health physio. So I'm just getting more and more into it now.
Yeah, no, I think it's phenomenal. I mean, have you kind of run into the same barriers from physios in Canada where they're a little adverse to it, or do you find that everybody's pretty open to, it's okay. It's almost like you're treating with your hands behind your back to some degree.
Yeah, no, I would say definitely there is pushback from many different groups of physios, and then I think also too of the public, because
Mhm.
then the public kind of gets a perception that the only valuable aspect of what we do with our expertise as a pelvic health physiotherapist means we always have to use that directed act
Right.
of doing the internal work. But it's quite flawed when you think of it, because we also have a directed act of spinal manipulation, for example.
Mhm.
And if you're an MSKPT and you have that, so I have rostering to do acupuncture, I have rostering to do spinal manips, I have rostering to do internal exams.
Mhm.
And, when I'm doing my MSK work, that doesn't mean I'm doing a spinal manip on every single person. In
Right.
fact, the more advanced I got, the less often I would use that
Yep.
skill. And so I have kind of seen it too with this other directed act. It's a really important skill to have. There are times when it's critical to really have the whole picture. But I think when you have a degree of expertise and experience and a really wide toolbox, you don't need that all the time. It
Right.
isn't indicated all the time. And I think when it's used too often by people who don't have a lot of experience, it actually creates harm. So, like doing some of that internal work.
Hmm.
And so, yeah, I know there has been pushback. I don't think there's good enough awareness of the substantiation of it for something like
Yeah.
pelvic health. And so that's why, to be fair, I'm starting to look at that because it's sort of a gap. It's a gap that's affecting sort of like our population health needs.
Right.
And so I'm kind of now working to try to ameliorate that gap.
Yeah. What has been the feedback from the patients that you've worked with? Have they come in kind of a little bit questioning whether it's going to be the same thing and had a different experience, or what's that been for you?
So I think for me, to be fair, by the time like clients have kind of have sort of have come in to see me, oftentimes they already sort of know that I'm the physio director of all of the wombs. They've maybe already kind of heard me on a podcast. Maybe they've already seen three other physios and they're kind of
Mhm.
coming to me. So I feel like I have a little bit of kind of like a sample bias that it makes it a lot easier for me, that
Yep.
people are kind of quite excited to kind of talk to me. And I explained to them right out of the gate. I say, look, like I hit the elephant in the room. I say, look, I can appreciate it might feel really interesting. How can I help you as a pelvic
Mhm.
health PT when we're going to be seeing each other virtually? And I hit it right on the head. And I
Yep.
go through and I say, like, these are all the things we do. Should we determine, before I had a hybrid model, so I would say, like, should we determine that we want to integrate some in-person care, we'll do that.
Mhm.
But now that I do more of a shared care model with anyone from my team at the 6 different rooms, I'll say, should we determine that we want to get you going with some integrated care, we will get you hooked up in a nice circle of practice with one of my colleagues. And I explain to them exactly how it works.
Mhm.
And always by the end of the first visit, people are saying, wow, that was so helpful.
Yep.
I didn't know we were going to actually uncover all of that, but I feel like so many dots were connected.
Yep.
I'm feeling a sense of understanding and hope and all of the things, right? All of the things that I think are the most important part of our role. I almost feel like you can accomplish it when you're experienced, to be
Yep.
fair. So I'll put that caveat. I almost feel like you can accomplish that better when you have the space and time
Mhm.
to just go through everything without the expectation of, okay, we have to hurry up because now we have to kind of get to these things.
Right.
So I feel like for me, it's been easier that way. I
Mhm.
can say that some of my newer, more novice team members have struggled more. Like they've struggled more to kind of operationalize things. If I'm being really honest, I wish more of my team members would have maintained more of a hybrid style practice
Yeah.
since the pandemic.
Mhm.
Some of them are, which is great. Some of them are kind of back to like 90% more traditional in person care.
Mhm.
So that tells me that there are real barriers
Yeah.
that need to be overcome, kind of from the perception of the public, but also sort of from sort of a PT confidence and training
Mhm.
perspective. And so I'm hoping to kind of assist with that gap.
Yeah. No, my experience is very similar to yours. I do a lot of consults, so like one-off, same thing where you have somebody that they've seen three or four therapists in their geographic location that still hasn't figured out their problem. And I,
Right.
I almost think it's almost so much easier for us because you can look at what they've done, and again, you're just looking for the gaps. We're
Totally.
able to sit at that 10,000-foot view and say, okay, well, that was missing, that was missing. We don't have information about that. That wasn't addressed. Like, and
For
and
sure.
I'll have patients that like they'll have seen people for years. I'm sure you have the same situation. And it's something very specific. Like with me with running, it's like, oh, running downhill, or
Right.
um, I don't get leaks until 8 miles in and my person can't figure it out. And we just literally 1 or 2 visits and they're like, oh, yeah, good. Finish the marathon. I'll drive.
For sure.
And again, I think it's because we have that experience of pattern identification like you have. But again, being virtual like this, I can really hone in and really emphasize my listening skills, my questioning, my critical thinking.
Hmm.
And it allows me to say, okay, with this information I have, this is my best hypothesis. We're going to try X, Y, and Z, and then you're going to go play and come back. So it really is that therapeutic alliance heightened and
For sure.
emphasized, which
For
I think
sure.
makes a huge difference. But I also, again, I grew up, I told you, south of Rochester in upstate New York, and our closest major medical system was Rochester, which was 70 miles away.
Right.
And I mean, I understand not having, here in Arlington, Virginia, I've got a PT like 500 feet from me in the building next
Hmm.
door that does MSK, like we're everywhere. But at the same time, there's so many places and people don't realize how big Ontario is, by the way.
Hmm. Hmm.
Ontario is huge
Totally.
and very rural in a lot of places.
Yes.
Um, People like again, you shouldn't be necessarily restricted. Your care shouldn't be restricted by where you live. And I have, it's so important to make sure that people have at least internet capacity to be able to chat with somebody. And here in the States, what they've done with licensure that's helped with that is we have the interstate licensure compact. So if you're part of a state, and this is where a little bit of state politics gets involved. So um, if your state is a part of that, then you can partner up with another state that has approved that. So for example, yesterday I had a client in Montana, and it was very easy for me, couple clicks, 30 minutes, and I have a Montana license. And this person, her closest PT is 5 hours away. So
Right.
like situations like that, it makes total sense.
Totally.
But again, I feel like when we're brought up thinking that this is what makes us special, and I think you and I have been around long
Hmm.
enough to be like, no, the longer we're at it, it's our
Totally.
it's not our index finger, like
For
do less
sure.
internal, all that stuff. But I wish we could like bottle that and put inside um younger PTs or more fresh PTs and be like, no, 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 it's here.
For sure. For sure. And I agree with you 100%. And I also wonder, like, is part of what has now evolved us and advanced our pattern recognition, did we need like some of that initially with our hands? And honestly, like, I guess I don't know, but this is why we have to look at it. Like,
Hmm.
is virtual pelvic physio maybe more appropriate for people who have had kind of a couple years experience?
Yeah.
First, like, even if I think of the model of nurses to nurse practitioner,
Hmm.
because I used to teach in the nurse practitioner program here in Ontario, you can only apply to get into that program after you've been a nurse for two
So you
years.
have context. Yep.
Right. So there's context. So I wonder about that, but
Yeah.
maybe that's actually not the case. So I do think there are a number of unknowns that we have a
Mhm.
duty to figure out. But I would agree with you, for seasoned, experienced PTs, I think we can actually use our skill set and scale it much more powerfully, actually, when we're doing virtual care. So I would
Yeah.
love it if more of us, like who were at
Mhm.
our level, Carrie, embraced it, right?
Yes.
To
No,
fill that
I
need.
agree. I agree. And again, you said something earlier about sometimes patients get a reliance on manual care, and I think that happens a lot in the chronic pain realm. You and I have
Hmm.
both experienced
Yeah,
that, but especially the perinatal population. Like I told you, we've got about a foot of snow here in DC, which is very strange. And even though it's melting and refreezing, I've got moms that are like, no, I can't get out because I don't have childcare or my car won't get out of the neighborhood. We just
right.
switched to telehealth. So
Exactly.
they don't have to put themselves on the back burner again when their kids have been home for 2 weeks over the holidays and then 3 more days. Like it's the
Totally.
87th day of winter break.
Yes, 100%. Like, I'm with you 100%. Or even like sickness and illness. Someone
Right.
wakes up, they have the flu, but they're feeling okay. They just don't want to be like contagious to
Hmm.
someone. But it's like, great, let's switch you over to virtual. We can still get
Exactly.
you cared for. We can still
Yep.
do this. We can still keep you empowered and on
Yeah.
track and
Yeah.
working towards all the things. Yeah,
Yeah. No, and
100%.
and and as a small business owner, that's been my saving grace, quite honestly, the last five
Hmm.
years, because everybody's kid has had every disease imaginable all at once.
Totally.
And again, it allows mom to put themselves first and not shove to the side. It also, again, makes it a safe space here that we're not worried about us getting sick too and then not being able to work. And so I feel like it there's a lot of logistics that it supports, but then also so much of how we look at physio. That,
Totally.
we went into physio thinking it was, just this manual sort of thing, but it is. It's all encompassing.
Mhm.
It's a lot. It's all the things, which is cool. So
Yeah, totally. I would agree with that 100%. Like in addition to overcoming some of like the access barriers and care barriers, I would agree with you that we have had a call to action in our profession to say, look, we need to be more biopsychosocial
Yep,
spiritual. Like we
yep.
we need to. I think we can leverage that much
Mhm.
better through doing virtual or at the very least like hybrid programming, like
Yeah.
embrace it to
Yep,
some degree, even if it's
yep.
not going to be as much as what some of us might be doing. So I couldn't agree with you more. I think it
Yeah,
will actually make our clinical skills better.
yeah. I agree.
um but I think it's coming. I think it's coming,
Okay.
so
Well,
yeah.
however I can help you, let me know because I'm
Yeah,
bored with it.
yeah, love it, love it. We'll stay in contact on that one, Carrie.
Exactly. Well, one of the areas that I think is one of the easiest to kind of target and notice patterns you've got quite a bit of experience with is pelvic girdle pain, not only in
Mhm,
pregnancy but postpartum. I feel like there's so
mhm,
many really easy to identify patterns with that. That's
mhm.
easy to identify, give home recommendations, whether virtually or
Yeah.
in clinic. Tell us a little bit about kind of your background with that and some of the things that you've worked on through the years.
Yeah, absolutely. So this is actually a really great area because I think it's an area where there is still kind of almost a behind notion of where things stand. Like a lot
Yep.
of people don't have a clear, evolved state of the science on this particular issue,
Yep.
but it's also a really nice example of, yeah, we used to think it was all manual and mechanical, but actually it's biopsychosocial spiritual. Like this is a really good example of that.
Yep.
And so, where I kind of really got interested in this particular pelvic pain pattern was really actually more through my teaching at McMaster. And so, the way our curriculum was structured at the time, and it's kind of been changed now, we had this like integrated unit at the end of the second year. And this is where we would kind of had everything's problem-based learning at
Mhm.
McMaster. It's similar to Harvard.
Yep.
And so, we had the client problem where it's a pregnant woman. She's having this pelvic girdle pain. She also started having incontinence. So it's the student's opportunity to start kind of learning about these issues.
Mhm.
And one of the things I think McMaster has done quite well in their curriculum is, the teaching of pain science, because we've been fortunate to have a lot of really good faculty who are pain science people and pain scientists. So it was so interesting to me that I felt like at McMaster, the students were actually getting that better than what a lot of other schools were getting. But then we would get to pregnancy related pelvic girdle pain at the end, and everything they learned about, nociplastic pain or central sensitization, or how do cognitions change the nervous system, and how does previous trauma, it's like that was all forgotten. And everything was back to looking at this purely through a biomechanical lens. And without fail, like year after year. And I thought, this is so interesting. Like, I
It's
wonder what this is all about.
It's so fun. I feel like the same thing happens with MSK or ortho PTs is they see somebody who's pregnant and they totally freak out because they think they're going to touch some like magic place that's going to spontaneously put that person in labor, which doesn't, trust me, I tried. It doesn't happen.
Totally.
Like people lose their minds over, oh my gosh, this person is pregnant. What do I do?
Totally. And I think that's part of it. I think part of it is a bit of almost like that fear factor.
Yeah.
Like you have this vulnerable pregnant person that's unpredictable, and that's like a disaster waiting to happen
Right.
potentially. But I think other parts of it, and now I know this because I ended up doing some research exploring it, is the narratives that we even have like culturally about this pain presentation are so strong. That narrative about relaxin relaxes the structures and they get too relaxed. They're moving too much. So the pain is related to too much movement and faulty biomechanics and now a faulty posture now. And because like it's such a strong narrative, even though we have systematic reviews that shows that's not the case, even though it's such a strong narrative, right?
Relaxin, I feel like there's some book that's like subliminally given out that when you find out you're pregnant, all of a sudden you learn a couple different words, and relaxin is one of them. And I don't know
Totally.
why this is still happening.
Totally.
So let's unpack that. Give us the real deal on relaxin so we can put this
Yes.
to rest.
Yeah, absolutely. So, yes, relaxin is a hormone that goes up a lot when you're pregnant. And yes, one of the things it does is soften tissue and make it a little bit more malleable. That makes sense. That's a very intelligent design given what's going to happen. The structures have to shift and evolve and accommodate. And then at some point, we have this feat of physics that has to be overcome where we need to get something large out of a small space, right? So makes sense that we're going to have built-in software to assist our hardware with that. Where things went off the rails was the assumption then that the pain experience in the back and pelvis that many women have experienced sort of since the beginning of time was assumed to be related to this software change,
Yep.
right? And to be fair, it's a reasonable hypothesis. It really is. You think, okay, well, maybe it's a reasonable hypothesis to be explored. But I mean, not only has it been disproven that, in a systematic review that was published in 2012, I mean, we're talking like 13 years ago, systematic review showing that relaxin and increased movement doesn't correlate with pain state. Period. The end. Like it doesn't. The other thing that pokes holes in it is, but everyone has relaxin. Not everyone has lumbopelvic pain. We also see that mamas who have had twins, which I do, they have 3.6 times the relaxin than a singleton birth. We don't see a higher prevalence of this in twins. Why is it then that if the relaxin of each mama is going to be sort of similar in each mama as she goes through her pregnancies, why is it that this issue is so much more prevalent the second pregnancy? So I mean, you poke holes in it every way, it just doesn't stand up. But I think because the theory is so plausible, and to be fair, some initial really really influential documents sort of proposed this connection. So for example, the European guidelines that were published in 2008, the European Pelvic Girdle guidelines, they weren't specific to pregnancy, but they were the first graded guidelines. And they sort of position that guideline around kind of this concept. And those guidelines have been very influential. So even though the very authors who authored that guideline have now gone back and said, you know what, actually, we didn't interpret the data correctly at the time, we still don't have this correct message, disseminated very well, unfortunately. Myself and Canadian physios, Canadian researchers on the other side of the country in British Columbia, just a couple of years ago, we published an infographic on this topic. And with an attempt to say, look, the state of the science is quite clear. It just isn't sort of disseminated very well. People still are sort of singing this old tune that this is a stability problem, that this is a relaxin problem. It's actually a nociplastic pain problem. It's actually a sensitivity problem. It's actually more of a physiological, wind-up problem. And so, we were inspired by some of the work that Professor Peter O'Sullivan and his group down in Australia did around back pain. They essentially translated the Lancet series, those 5 really dense papers that sort of really told us where things were at with lower back pain. It's not related to posture. It's not related to core stability. It actually almost never relates to structure. And they created sort of 10 myths in an infographic. And we thought, you know what, we need to do something similar for pregnancy-related pelvic girdle pain. And we did. So we are trying to kind of get the correct messages out, but it is slow. I mean, it
Yeah.
really is slow. And I give actually the um, Physical Therapy Association, the Academy for Pelvic Health Physiotherapy in the States, some credit because in 2017, Susan Clinton led that antepartum guideline.
Yep.
And that guideline kind of showed squarely that, okay, when it comes to assessment, actually the most important thing to assess is pain catastrophizing and fear avoidance,
Hmm.
right? So that was quite, I think, new, but really kind of following the data and saying this
Hmm.
is really kind of more of an integrated thing. And then Adrian Simmons,
Yep.
led the postpartum guideline, which also kind of flagged, this is an integrated kind of issue.
Yeah.
And yes, we have data to support things like manual therapy or compression wear, but it needs to be in addition to sort of education and pain education
Hmm.
and movement and really instilling this kind of confidence back into the person.
Hmm.
But even I would say some of those guidelines still ask their questions through the lens of a bit of bias.
Right.
And so right now I'm leading the update of the antepartum for the Pelvic Academy in the States.
Fantastic.
I'm chairing that. So that should be published by the end of the year.
Okay.
And we've really expanded our questions. So we're looking at lifestyle interventions. We're looking specifically at pain education. We're following what came out of the Delphi consensus on this topic. And we're actually looking at that because a lot of these questions still aren't even asked by researchers because their own questions to guide research are still in vacuum, if that makes sense. So we're trying to change that.
Well, I'm thinking kind of, just some parallel conversations, I've had with Dr. Christina Private about, and even just some stuff that came out with a research update with Taryn Halam in Australia, just looking at how we've underdosed exercise
Mhm.
in pregnancy. And I think you and I are in a lovely position to be able to reflect back on that with our, kids being the age that they are, and we, speaking for myself, like it was very do gentle things,
Mhm.
there wasn't this encouragement and even looking at abdominal strengthening and things like that. I've completely changed my approach, even in just the last year and a half, on
Mhm.
how we train abdominals in pregnancy, how we're not avoiding anymore. And that really was the culture,
Totally.
and what we were kind of taught to do. And I think, going back to your expertise with diastasis, I navigated diastasis after my second. But again,
Mhm.
this was back in the day where you wrap the TheraBand
Mhm.
around, you pull the two sides together and hope and pray that when you do your abdominal exercises, it goes back. Like, I feel like we are worlds away
Yeah.
from this very conservative approach, and our kids are, barely in, middle and high school. Like, there's a lot that's changed to how we view exercise. Instead of being worried about safety, it's like, actually, let's stop making people scared of moving. And I'm curious if that would be reflected in kind of that fear-based kind of perception related with pelvic girdle pain.
100%. And what you just said there kind of integrates like a little piece of work I've literally just put together with my FIFA team,
Hmm.
right? And you're quite right. Part of us getting to the point that we can appropriately load and
Yep.
train and develop robustness and fitness capacity in our pregnant mamas, and even more importantly, like our pregnant elite
Right.
footballers, right? For the perspective of FIFA,
Yep.
one of the things we need to make sure that we have clear is that symptoms and these certain experiences don't typically correlate with injury or damage the way we think we do,
Right.
right? And what's been really interesting for me working in the sports space, because that's actually a bit newer of a space for me, is the recognition that everything we kind of know about pain science, like as PTs and as pelvic PTs, because I really feel like we champion this beautifully, that has not made its way into sports med.
Right.
Sports med still kind of assigns pain as nociception and really follows kind of like an injury prevention protocol around
Right.
pain. And so it's critical because with pregnant mamas, we have sensory attribution. Every pregnant person has that.
Mhm.
We need to understand that a pain experience is an output and an opportunity to get curious,
Right.
and more likely relates to sensitivity, not injury or not instability, unless there's a mechanism that would point to injury. So I even still think like we have some work to do there,
Mhm.
because I think sometimes underdosing still
Yep.
is these athletic mamas who
Yes.
still are interpreting pain not as sensitivity,
Yeah.
but as an injury, and being like, oh, okay, I'm going to be back off and be careful, instead of saying, you know what, I'm going to get a little bit curious, because pain is a communication. And I'm going to think, okay, like, is it actually that my structures are just a bit tighter and holding tension? And that's why it feels that way? Is it that my sleep the last 2 nights wasn't great? Is it that I had that really distressing phone call with, my boss yesterday and my system's a bit wound?
Mhm.
And instead of doing that, they might kind of automatically like scale back for a number of weeks.
Right.
And right. So
Mhm. Yeah.
I still think that we need to make sure how people interpret and make sense of their symptoms
Mhm.
is sort of as accurate as possible, and moving as far away from fear mongering
Right.
than it can, right? Like the same goes again if we're going to talk about diastasis. Like
Yeah.
a lot of that fear around, okay, I moved and my abdominal wall kind of like moved or distorted a little bit. Yes, it maybe stands to reason that tons and tons of really aggressive distortions may theoretically compromise that tissue. But if it's just the odd little sort of thing here or there,
Right.
that is absolutely no reason to monger fear and then move away
Right.
from a fitness protocol. So I think there's like a few different ways that some of these things intersect, but
Yeah.
I think we're getting there, but we still have a ways to go, I'd say.
Well, and I feel like there's so much overlap too, if you look historically, even just women participating in sports in pregnancy. Like there was this fear of, oh, I don't want to get pregnant because, I'm not going to be able to perform because I can't do my sport because it's dangerous and it's
Totally.
not. And or I'm gonna be pregnant and I'm going to continue to do stuff, but I'm going to not tell my sponsor because if I tell my sponsor, they're going to drop me and then I can't get paid. And then it
Totally.
just like there's all that stuff that gets wound together. And then same thing with early postpartum, this fear of, oh my gosh, I can't do anything. And I don't know that our profession has, I feel like we've kind of done a disservice to a degree over the
Hmm.
years with that as well of, okay, don't do anything till 6 weeks. Now we're seeing patients, 2 to 3 weeks postpartum just to get that stuff. Like, don't let them go down that rabbit hole of doing nothing.
Totally.
And, you know, and again, back to virtual, I'm like, if you have a question, I'd rather you tell me. I don't want you to go down that rabbit hole because it's ugly. All
100%.
those things. I feel like there's so much overlap in kind of the progress that we've made, even just bringing athletes, like everyday recreational athletes, but those elite athletes along for the ride. And we've seen so many more elites, several in the Olympics this year that were pregnant, some coming back, relatively early in postpartum. Like, I think because we're starting to see evidence that, okay, this is occurring, these conversations are more likely to be because people see that and they're inspired. But I
Totally.
also appreciate some of the athletes saying, hey, you know what, I had problems where I had, bone stress reactions or things like that. Like, there's going to be these other things going on. But the fact that we're pulling that whole conversation forward, it's just this big movement right now, which I love.
Totally.
Yeah.
Totally. And I think, again, it speaks to why we
Yes.
need to kind of be looking at all of those domains, because you're
Yep.
quite right. If an individual is supported in the way they need support,
Yep.
they typically are going to do well. And so we know, like, even if we're talking about pregnant athletes, for example, we know that when you're pregnant, that's an independent risk factor for some pelvic floor dysfunction. We know that for an athlete, even if they're not pregnant, if they're doing high impact, that's an independent risk factor for pelvic floor dysfunction. So pregnant athletes, well, they have double whammy independent risk factor. That doesn't mean they're going to have a problem, but that means great. We can kind of come in and make sure that individual is bolstered and supported as best as possible,
Yep.
knowing those things. And I feel like that's kind of what we haven't done well. We've had people kind of go through without the proper tailored support to their needs. They don't have a good outcome. Then we're like, see, athletes, pregnant athletes can't do that. And it's like a false conclusion. It's like,
Yep.
well, no, actually, people need the support to carry out the demands they need. Like that's what the conclusion should have been.
Right.
And we didn't do a good job on that.
Yep.
So I do think there are a number of us working on this in different ways to try to help. But I also would agree with you. It points back to the virtual care because again, like at 2 weeks, that probably isn't really going to be a time you need to get your hands on someone or should because someone's healing. But that's still probably a really good juncture to kind of talk through a whole bunch of these things. Even something as simple as nerve regrowth factors stimulated through muscle contraction. Let's start stimulating, nerve regrowth factor of your pudendal nerve. Even if you didn't tear in your birth, we know that nerve stretched to the point that likely denervation happened. Why are we kind of waiting till 6 weeks? People have done nothing. And then, so I agree, there's so much opportunity, but this is where I see the virtual care kind of feeds in these gaps too. Yeah.
Well, and again, continuing, like once we get women on this pathway, continue it forward. And I mean, I know since I kind of dove headfirst into perimenopause, just I look at postpartum completely differently now, just integrating that hormone perspective. And there's so many parallels there.
Totally.
It's like, I wish people wouldn't just like be like, okay, I'm on the pregnancy postpartum treadmill and then I go fly off and then eventually I'll hop on a completely different one. They're not that different.
For sure. For sure. And what I would say too, and this again comes back to our talk about athletes, the more mamas are delaying their reproductive time in their life. And a lot of the times these pro athletes do because they're kind of worried they have to pick either their career or family, right? Like thankfully that's starting to shift, which I think is really good. And hopefully they won't delay as much, but we're seeing more and more mamas who they're in postpartum, but they're almost starting to slip into perimenopause, like at the same time. And so like we have to be thinking about kind of teasing out those things too, right?
Yeah, and there's so much overlap. Here in DC, my average new mom patient is 38 to 42. Like we're
100%.
It's pretty normal here.
Totally. We're seeing the same thing here.
Yeah. So I mean, that's a conversation. Again, planting those seeds. So it's not this just like isolated moment. Okay, we're here. We're only talking about this thing. It has nothing to do with what's coming up. It's like I want to plant those seeds so that we're going to come back around again and come back around again because there's themes, those threads, they definitely carry through. So
100%.
yeah. Yeah. Another thing that doesn't come up enough, and I know I scrolled back through all of our episodes and I don't know that we have ever talked about this, and you've got some Canadian guidelines that have just come out, is anal injuries,
Yes.
anal injuries. So talk to us about what those are.
Yeah.
If you've never heard of them before, and then kind of what's some of the work that you've done kind of getting those guidelines going in Canada.
Yeah, absolutely. So when we're talking about OAC injuries or obstetrical anal injuries, we're really talking about those 3rd or 4th degree perineal lacerations, right? So for people who aren't familiar, when you birth your baby, if you sustain a tear to the perineum, it's graded on this 4-point scale. So grade 1 is just a little bit of the skin. Typically, that doesn't even require stitches of any kind. A 2nd degree tear is going into the actual muscle, into the pelvic floor muscle. That will be stitched up. That is probably the most common type of tearing that occurs. Thankfully, that type of tearing isn't consistently associated with a lot of sort of, pelvic floor morbidity issues. But then we have these 3rd and 4th degree tears that are going right into the anal sphincter, right into the rectum. And so these are classified as these oasis injuries. And so as far as clinical practice guidelines are concerned, I mean, my bias would be, we'll just have a guideline around sort of, preventing tearing anyway.
Right?
But it's so interesting that we sort of have accepted that a lot of people will have these second degree tears. We kind of know that even these second degree tears actually are associated with a lot of the kind of procedures and medicalization of how we kind of do birth in Western countries. And so I think just a degree of that is just accepted. And, there's a lot of conflict of interest and no one kind of wants to touch that.
Mhm.
So there are now these guidelines around trying to prevent these really bad tears, because these really bad tears are clearly associated with increased morbidity, like really severe incontinence, avulsions, pelvic organ prolapse, like these more severe issues, anal incontinence, etc.
Yep.
And so the most updated guidelines that we just worked on, it was a part 2. So we did such a comprehensive look at this issue. We were updating guidelines that had last been published in 2015. So way overdue for an upgrade. But what was really exciting about these guidelines was that, I was on this committee, and I was on, interestingly enough, actually as a researcher, as a PhD. There isn't actually room on these committees for pelvic health physiotherapist representative, which is interesting. They have mandates that they want to have midwives. They kind of want to have the spectrum of obstetrics care, but they always want to have like a researcher on these different things. So I've been able to kind of really lend my voice from the pelvic PT side, but kind of through the umbrella as a researcher.
Very stealth. Nice.
Yeah. So this has been really good. And what's exciting is both of these guidelines, the part 1 is actually already published, and then the part 2 is actually going to be coming out. But both of them have quite a big focus on the role of pelvic health physiotherapy and have actually now very specific recommendations. So I'm excited to say that now for all, it's now recommended on these Canadian guidelines that anyone who has sustained a 3rd or 4th degree tear should absolutely be referred on to pelvic health physiotherapy. And that is like a strong graded recommendation. And then there's another recommendation kind of saying, you know what, like really there's kind of benefit for even some of these other like non-in-person forms of physio if you can't access in person,
Yep.
which I also think is important. Like we kind of talk about that in the guideline as well. And then there's another kind of mention about the benefit of pelvic health physiotherapy for a lot of the different sort of symptoms or issues that come along with one of these tears.
Mm-hmm.
So that certainly is definitely like a much more clearer recommendation in place for pelvic health PTs to kind of step into this place.
Mm-hmm.
And that's going to be indicated in both the part 1 and the part 2 guideline, which is exciting.
That's fantastic. I mean, here in the States, we had, I think ACOG in 2018 put out their 4th trimester guidelines, and
Yeah.
we were barely mentioned.
Yeah.
And
which is so disappointing.
well, I mean, it was a start. So thank you for the acknowledgement. However, and there were several of us. Susan Clinton was part of that. Jessica McKinney. I think there was somebody else on that as well. We wrote back and said thank you. However, we can do kind of all these other things. We should kind of be in all of it. And I feel like, same as you, when you've been at it as long as we have, we're like, no, we can help with all of these things. Please throw us on. We'll help. But I think, especially anal sphincter injuries, anything related to, I think fecal incontinence, smearing, loss of gas, anal gas or things like that. Like, I feel like those topics there's so much more shame, so much, less likelihood for people to seek help or realize that there is help for it.
Totally.
And I think, it's also, people think, oh, well, that's just how it is. I tore, can't do anything about it. And it can be really, really devastating for moms where, you're not only navigating your own issues, but you're navigating, your new baby, all this other stuff. Like, it can be devastating.
Totally.
So I think to normalize saying, hey, if there is a tear anywhere, just do the referral. Just do the
Totally. And I agree. Like, I mean, as much as like, it would be amazing. They're like, if any tear at all, send on, rather than now it's just for these types of tears.
I know.
But you're quite right. It's a start. And what it's possible now where some of these recommendations might go, there certainly has been an interest with a group of physiotherapists here in Ontario saying, why aren't we as pelvic PTs actually kind of integrated into the hospital system? Like when there's something really severe, like a point of care of someone kind of right there. And I think there's a reasonable argument for that, so could guidelines like this justify, the use of a PT on the ward, that anytime there's a 3rd or 4th degree tear, that PT can come and kind of give that sort of reassurance and counsel to that client right away to say, like, this is something that we can and will work on. We can ameliorate these issues. So you're right. It's a start. Again, it's great. I still think we have a ways to go, but that's okay. We're a motivated group, and we'll get there.
Well, and that's where I feel like there's two conversations. One is like, let's organize how we should do this, for ideal care medically. And then I feel like there's so many other variations of access to medical care in the world. And I'd love for you to just kind of chat about kind of what access looks like in Canada, because here in the States, we think everybody else has it better. And it's not great, I'm not gonna lie, but I also think that we've got some good things going as well. So for just to start as a physio, and you kind of mentioned a couple of these things through, I forget the word that you use, but you have a certificate or approval to do certain things. So maybe talk us through a little bit of that. And then also, like, what's the process as a pregnant mom? How do you access physical therapy? And is it all you just kind of have to wait in line, or how does that all work?
Yeah, absolutely. I think it's a great question. So things are similar in each province, but a little bit different. So I'll really speak from the Ontario context. So when you graduate from your program at, in Ontario, there's 5 universities that have a physio program. So when you graduate from one of those programs, you have to write a licensing exam, you have to do a clinical exam, and then you can register with the College of Physiotherapists of Ontario. And so that's you being sort of an entry-level person. Any of our established sort of delegated acts or rostered acts, you have to actually indicate that you have developed competency in that to then be rostered under that category. So as I alluded to, there is spinal manipulation, there is acupuncture, there's increase, like putting your finger in past the labia majora, like that's the exact wording. And then there's O2 administration, oxygen administration. I think those are the only 4. And so you have to deem that you're competent and be rostered in that category. And then for anyone sort of who is a resident of Ontario who wants to seek the care of a pelvic health physiotherapist, for the most part, this is going to be privately. There are a few kind of integrated team-based centers that we call family health teams that have a physio on the team who has, pelvic health kind of rostering or training. I want to say of like the 200 teams in Ontario, there might be like 3 that have this. So it's very few and far between. And there are a few of our kind of OHIP funded like physio clinics, which is really kind of diluted style physio that have a pelvic PT. So really that style of pelvic PT probably wouldn't resemble closely to what you or I are doing, right? To what you or I are doing, that lives in the private sphere. The good thing is, though, is that most people's benefits, like private benefits plan, covers off physiotherapy, like the majority. So most people, as long as they have a benefits plan, will almost always have some coverage for physio. And then you don't need a doctor's referral. There's no red tape that way. They can just go to whatever clinic they want and go and pay for the visit and then submit their receipt to their insurance and they get paid back. So like that's actually quite straightforward that way.
Yeah, we're a little more complex down here.
Yeah. So fortunately, like that's better. It still means the people who don't have the benefits coverage, if they can't just afford just to pay for it, because that's another option, they are the ones that get left behind. And we know a lot of those people actually have more of the factors, that they're the ones that need help, but I would argue like they could be helped so easily with even just a couple virtual visits. Like there are ways we can get those people care that isn't
Yep.
that expensive, you know? But yeah, so things are relatively straightforward that way, at least here.
Yeah. No, and that's where, I mean, I've been a huge advocate for, it almost as a responsibility to be able to put out some free information and free content so that people have the opportunity, if they don't have access, like you said, to be able to
Hmm.
at least start to understand what's going on with them. And if they do seek care, they're not just kind of, shooting a dart at a dartboard and hoping it sticks. They have a better sense of kind of who to talk to and that sort of thing. But yeah, I mean, as much as we complain about access down here and red tape, unfortunately, I live in a state where we have full direct access, which is fantastic, and
Hmm.
dry needling and so on. I know it could be better.
Right. Totally.
I
Totally.
think
Yeah, I
you
would
could
say
say
the
that about
same.
the world.
Totally. We got it pretty good, but could be better, but we
Yep.
do have it pretty good, thankfully.
Yeah, but again, and again, I think you and I are similar vintage where it's been such a huge change across the board, not only in physio but in just perinatal care across the
Hmm.
board, access to information, those sorts of things, kind of how we understand information, even just having researchers like yourself, women getting PhDs. I think that's been such a huge push forward, which only bodes well for us
Yeah.
to have more and more conversations. So
Yeah, totally. What I
yep.
will say that's interesting about the perinatal space is the issue of cesarean birth. You know, that is the number one surgery done in Canada of all surgeries. It's the number one surgery done. And in the physio curriculum, literally until last year, it wasn't covered at all. And when I think of all my colleagues in private practice in MSK, it's the number one surgery done. Like all physios need to at least understand this surgery. You're going to be
Yep.
working with people who have had it. And so, like, now we have just integrated that sort of into the curriculum, but I really had to push and advocate for it, right? So at the end of the day, it's also like some of these curriculums are sometimes dependent on who's sort of on the faculty really advocating for it. I
Yes.
teach in the medical school at McMaster too. So the family medicine residents, they get to learn
Hmm.
a lot of these kind of basics about pelvic health and kind of how to kind of assess and how to assess with a physical assessment, how to assess properly with screening tools, how to properly initiate pelvic floor muscle training, but what other tools, how to refer to physio. No other medical schools in Ontario get that. So that's the other thing is that we have enough data to support excellent sort of conservative care through perinatal care and pelvic health. Like we
Yeah.
need it integrated a bit better in the curriculums even.
Yep.
So yeah, so again, like we're getting there. It's exciting, but
Yeah.
there's still a lot of work to do.
Same here. I mean, there's like maybe a handful of questions on our national physical therapy exam that are specific to moral. And the thing is, like, they don't consider like menopause or anything like that.
Right.
Pelvic health. That's not pelvic health content. Like it's these very specific things. But I don't think anything's on there about major abdominal surgery, like a C-section, which is incredibly common. But
Totally.
that's where I feel like more of us. And I did a stint writing exam items for the NPTE. And it's hard. I'm like, okay, I've got to write this many questions and I've got this topic area. I am going to weave in some sort of pelvic
Totally.
women's health, something, however I can.
Yeah, totally.
Because I mean, when you have that much of the population that's female, those things are going to come up. They're going to play a part of these conversations. So I'm always,
100%.
so if you're a
100%.
physio listening and you want to, you're good at writing exam questions.
Yes,
Your
your
brain
skills
has
are needed.
your brain has to work a certain way. My brain does not work like that at all. I'm so much in the it depends land. Like it's not good for it's not good
Totally.
for those questions. Very hard for me. All right. At the end of every episode, we have a couple questions that we ask. All right, what's a book you're reading or a podcast that you're listening to right now?
Oh, so a podcast that I am listening to right now is Tracy Donegan's podcast. This is a newer podcast. She's someone who I have collaborated a little bit with in research. She is actually the founder of Gentle Birth. So it's kind of more of a philosophy, but then she actually built it into an app, and we've kind of done some collaborations together. So her podcast is quite new. So it is now one that I'm listening to regularly, and it covers off some of these topics. So it might be of interest to the listeners. So yeah, Tracy Donegan's podcast.
Sounds good. All right. Since you have high schoolers now, which again, like, how could we possibly have high schoolers? Because
I know.
teenagers, right?
Right.
What's your favorite activity since becoming a mom of twins? What's been the best part so far?
Like activity with my kiddos, or just my activity myself? So I would
not have to be.
So I would say that as soon as I had them, I got very much almost like out of my gym and really kind of walking the trails around my house, because that was a task I could kind of do with them. And even though now they have moved on to me not needing to do that, and I've gone back into the gym, I really have found like a lot of grounding in my trail walks. So that is kind of something that I try to almost start every day with, like my walks. And I find if things get pretty hectic, and I kind of am not doing it, like I really do notice I'm kind of dysregulated. So that I would say is something that, yeah, it really brings me a lot of like joy and grounding, is like my nature walks and my walks. And it's something I got into, funny enough, actually, because I had them, but now I've actually really held onto it, even though they're kind of more independent now.
That's awesome. Are they like dirt trails or paved trails, or what are they?
Yeah, they're dirt trails. I'm so fortunate. I live in Oakville. It's just west of Toronto. And we have these beautiful trails like all over the city. So it's nice. I'll sometimes do the ones around my house, but sometimes I'll kind of drive to a different part of the city. We also have the lake right there. So sometimes I'll do the path on the lake. And yeah, I really feel like that is key for me to kind of keep myself balanced and regulated to be doing all the things I want to do. So yeah, definitely walks in nature.
I think there's research that says like you see a tree or nature or walk by water or something for a couple minutes or something like that, and you've got brain changes. So I think research is supporting what you're doing.
Yes, it is.
All right. If you had one piece of advice for moms and you get to pick the stage, what would that be?
I almost think it would even be for like people when they're starting to think about being a mom, like when you're almost in like your pre-contemplation stage of kind of mothering. I think actually that's a really good time to kind of start thinking about you and self-care and some of those things. Because I mean, you know, there is an argument to be made, and we have some research that substantiates this, that like once you are pregnant or you've had a baby, or there's been anything that's gone on to disrupt the pelvic floor, it can be sometimes a lot harder to kind of figure out how to kind of get it to function better. So there's an argument to be made to say, like, when the system's sort of like really intact, like that's a great opportunity to kind of just understand your anatomy. And a lot of women, even before they get pregnant, like don't have the best understanding of kind of some of this stuff. Like some of them think it is normal that they've kind of had sort of painful periods every time, and they just kind of think that that's part of being a woman. And if they can kind of know, like, no, actually we see that correlates with an inflammatory profile and sometimes a bit of sensitivity, and that's an independent risk factor for later sort of pelvic pain. And if people can kind of learn a bit about that when they're thinking of getting pregnant, I just feel like that would go so far. Like the most recent NICE guidelines that were published in 2021 actually have a recommendation in there for sort of prevention purposes, that adolescents, like teenagers, once they start getting their menses and their infradian cycle kind of kicks in, that is the time they should start learning about pelvic health. And I would agree with that. Although at the same time, like teenagers where they're at, I can appreciate that won't really be what they care about. But once someone's at a point where they're at this conscious conception point, like I
Mhm.
am ready to become a mother and conceive, I think there is a little bit more of a shift there.
Mhm.
And I think there's more we could do at that juncture to get some
Yep.
of this in.
Yeah. No, I'm totally with you. I mean, my youngest, my daughter's 11, and sh we were on the ski slopes the other day, and they had, I think they were playing, like, Christina Aguilera, "Genie in a Bottle," and she's like, it's a vintage song to her, right? And I was like, "You know what that's about, right?" And she's like, "No." I'm like, "It's about sex." She's like, "Eh," so we can't have those conversations. She's like, "Don't
Totally.
talk about that anymore, but we can
Totally.
talk about, hey, these are your parts, and this is why you need to, shower now that you're a little bit older every day, and kind of keep your parts clean, and
Totally.
those sorts of, like, and that's what I'm learning is like, okay, how do we? She's not ready for that one yet, but how do we introduce these
Totally.
concepts early and often? And I don't know about you, when I have a patient like in their early 20s, and they tell me about, they got their cycle when they were 9 or 10 and
Hmm.
had painful periods for 10 years, and
I
I'm
know.
seeing them in their early 20s, and and I know that's early for us to, have a
Hmm.
hand in it and be able to help them. But your heart just breaks. Your heart
Totally.
just breaks that somebody wasn't
Totally.
there for them sooner.
Totally. And that
So,
they started to learn that, like,
mhm,
this is just their lot in life. And this is, I
mhm,
guess, just how female bodies behave. And this is, and
yeah,
now we know a lot of kind of sensitizing has gone on because of that. And
right.
you're right. Like it's sort of like, yeah, let's go upstream. If we can go upstream to prevent these
Well,
things,
but then also me processing perimenopause and menopause while she's on her way into it, I was like, okay, we've got to do a little filtering there too.
Yeah, totally. But that's why we can bring in like external
Yeah,
people to
right.
say, you know what? Like
Exactly. We
you
delegate that
deal
out.
with, yes,
Yes.
yes, yeah,
Yes. All about the delegation.
100%.
All right. Who is somebody, you're going to have to work hard here because I think our networks overlap quite a bit. Who is somebody in pregnancy postpartum space that we should know about? And you get extra points if it's somebody that either hasn't been on the podcast or I don't know.
Okay, so I would probably say Alex Frankham. Do you know who that
Okay.
is?
No, that's why I'm
No.
excited. I'm going to write
Okay.
this down.
So she
Okay.
is brilliant and
Okay.
she is in Jersey in the
Okay.
UK. And she and I have collaborated a little bit on pregnancy related pelvic girdle pain. So we've published a couple papers
Okay.
together.
Cool.
She recently wrote like a brilliant commentary on this topic.
Mm,
It was published in POGP. It was just published last year in 2024, 2023.
okay.
And she is just about to start her PhD.
Oh,
And
beautiful.
she does some teaching, sort of in the UK. So I think
Hmm.
she's a bit of an up and comer that we're going to
Okay.
start to see more and more from.
Nice. Yep.
But she really is quite a brilliant mind, and she's really
Okay.
articulate. And yeah, so Alex Frankham, she's awesome.
Yay. Oh, you got extra points. Well done.
Yeah. Okay. Great.
All right. And then what does it mean to you to be an active mom?
It means a couple of things. So I would say it means for me to kind of be physically active to kind of keep myself healthy and regulated and kind of all the things I need to do. So that's kind of my resistance training in the gym and my walks, but also my yoga and kind of those things. But it also means like being a really good role model, right? And really like making sure my kids are seeing that. Like I'll tell them, yeah, I'm going to the gym now, I'm doing this, and really making sure they understand
Mhm.
that that's important, and also helping them to understand that like being active can look like different things at different times.
Mm.
So for example, like my son plays rep hockey and my daughter is a competitive Irish dancer,
Oh, wow.
and I've kind of helped them to understand like that's great. Like you guys get enough activity in kind of what you're
Mhm.
doing
Yeah.
through your kind of sport. But at some point, you'll probably hit a juncture in your life that you're not doing one of those things. And
Right.
you still need to always move and be healthy. And it's
Yeah.
kind of weaving in those little conversations kind of
Yep.
for modeling. But then also legitimately like keeping my own infrastructure and my body, mind, spirit healthy. And one of the most powerful conduits of that is activity.
Yeah.
So yeah.
I love that. I love that. All right. If you guys want to hear more from Sinead, you can find her over on Instagram at dr.sinead. Sinead Dufour, thank you so much for joining me on the show and appreciate all your insight and excited to hear about that part two of the guidelines coming up.
Okay, amazing. It was great to talk to you, Carrie. Thank you.
Thank you. If you're navigating pregnancy, postpartum, or perimenopause, whether personally or professionally, check out all our free resources and upcoming courses at carriepagliano.com. This podcast reflects the opinions of Dr. Carrie Pagliano and her guests, and it is for entertainment purposes only and should not be considered medical advice. Always consult your healthcare provider with any medical questions. If you enjoyed the episode, please take a moment to leave us a 5-star review on your favorite podcast platform. And thanks for listening.